From 11 to 11:30 on WBBP, WMBA, 99.3 FM, and Facebook Live. Now, with no further ado, let's welcome host Mike Romide to introduce today's program.
Well, welcome to the best of Beaver County. How's your liver? I can't think of any other way to start this segment of the program but to ask that. How is your liver? Chances are you don't know. Chances are people going down the street and seeing you with that beer belly say, yeah, he's not doing too well there. But we all have one. We can't live without it, right? And the liver is one of the organs that we have that is multidimensional, and it heals itself. It's not like you smoke and you get lung cancer and they say, well, I don't know what we can do for you. But if there's something wrong with your liver and you need a liver transplant, you find a match and they can pretty much, the liver can pretty much heal itself. Why am I telling you this? Because our guest this morning is Dr. Karen JEROME-ZAPADKA. Dr. Zapatka is a gastroenterologist, and full disclosure, she's my gastroenterologist. But she's educated herself over the years. This is a woman who has definitely continued her education in many facets of healthcare. She has now formed Trajectory Health Partners. She's the founder and medical director. And Dr. Zapatka, welcome to the show.
Oh, thank you, Mike.
It's good to have you here.
Great.
And you can speak as loudly as you want.
Okay.
The microphones will pick you up. This is a little different from what you're used to, is coming in a studio and talking about things. But it's not because you don't have the knowledge. You're very knowledgeable about this sort of thing. Gastroenterologist, you've been practicing that for, what, the better part of 20 years?
Over 30 years.
Over 30 years now. Amazing. And through your education and through your practice, you have found what that started to lead you in the direction of liver and people with fatty liver. And when I mention that fatty liver thing is because anytime we've been to the doctors, you probably the same. If you're of a certain age, they say, well, you got a little bit of a fatty liver, but everybody has it. What are we learning now about the liver?
Yeah, what we're learning is, well, when I first got out into practice, the main liver disease we were seeing was hepatitis C. Oh. And we went through so many iterations of medications, some of them fairly toxic. Mm. But we got to the point over the past several decades that we now can treat hepatitis C with a few pills over an 8-week period or so. And most patients can be put the hepatitis C into remission. But as that was waning, we began to see another type of liver disease we used to call fatty liver disease, non-alcoholic fatty liver disease. And in my career as a gastroenterologist, I began to see what has become a pandemic unfold before my eyes. Mm-hmm. And I very first started getting interested in obesity probably about 20 years ago, when we began to see a lot of the GI cancers that they thought were related to obesity, esophageal, gastric, pancreatic, colon, for example. Mm-hmm. And so I just started thinking, what is it with these cancers? What is going on here? So that led me down the road to get my certification as an obesity medicine specialist through the Obesity Medicine Association. But as time went on, it started to become clear that these cancers were probably more related to a metabolic disorder, to underlying insulin resistance, to something that we call metabolic syndrome. And in fact, the new name for fatty liver is metabolic dysfunction-associated steatotic liver disease. It's a very long name that now recognizes that what we used to think of as non-alcoholic fatty liver disease is a metabolic disorder. Mm-hmm. Associated with insulin resistance. And so that led me down the route of getting a certification called Metabolic Health Practitioners through the Society of Metabolic Health Practitioners. And so now I have this third certification that is geared toward metabolic health rather than just obesity.
So it's interesting because you're saying this, and I'm thinking, get out your pen and start writing down these things because you talk about esophageal and different things. Mm-hmm. And it was like people, and they still do have acid reflux. Mm-hmm. And it causes the people who have that, great pain, and they have to go through these things. Are these all things that are associated with what you're talking about?
That can be made worse by obesity, no question, worse by nutrition. I would not consider acid reflux a true metabolic disorder.
So obesity, and you talk about liver disease, fatty liver, and whatnot. When we used to hear about people who had liver disease or cirrhosis, first thing came to mind, it's an alcoholic.
Absolutely.
Right? But that's not the case.
That's not the case anymore.
Okay.
And that is what we really want to drive home with patients, that yes, alcohol is a cause of fatty liver disease and cirrhosis from fatty liver, but the pandemic that we're talking about now is related to lifestyle, nutrition, sedentary behavior, lack of physical activity.
Okay.
And with the prime drivers of being our ultra-processed food diet, fructose being one of the leading drivers, carbohydrates of certain types in excess of what our bodies can handle.
And how, until a person is diagnosed with this, how do they know that they're causing harm to their system?
And that is the key, and that is one of the driving points that we're trying to teach patients. We don't want to wait until someone has an x-ray that shows fatty liver. We don't want to wait until someone is diagnosed with prediabetes. We want to have patients take a look at themselves and say, what can I see with what I have as far as my weight, my waist circumference, and my blood work that would give me clues that I am at risk for metabolic syndrome, insulin resistance, and fatty liver. And so those clues are very simple. It's looking at your waist. And if your waist is greater than 40 inches for a man and 35 inches for a woman, that's a clue. If your waist is more than half of your height, that's a very good clue, very simple measurement anyone could do. If you look at your blood work and your blood sugar is over 100, if your triglycerides are over 150, if your HDL is less than 40 to 50, depending on if you're a man or a woman, if you have high blood pressure, those are all components of the metabolic syndrome. And if you have those, you are at high risk to have metabolic syndrome, insulin resistance, and at high risk to have fatty liver.
And so all those things that you talked about, all the symptoms, affect the liver.
Yes.
Attack the liver.
Well, they can be clues that you have insulin resistance, and insulin resistance is a driver of fatty liver.
Insulin resistance, our bodies, from what my little understanding of it is, our bodies create. We manufacture our own, right?
We manufacture our own insulin to help us deal with the food that we have eaten, particularly carbohydrates, to help manage those in our body. As we become insulin resistant, our insulin levels go higher and higher and higher. And that's one of the part of the driving force behind building fat in the liver is that high insulin level. That's part of the picture. And
insulin is something that diabetics know all too well about.
Yes.
Childhood diabetes and adult diabetes.
Yes.
Diabetes.
Childhood diabetes type 1, they don't produce insulin. In adult onset type 2, we're producing too much insulin. And then we've become insulin resistant. And the end stage of that is type 2 diabetes.
Oh, okay. All right. And so those are all problems. Tell us about the trajectory of business and how you got into this and what you're trying to achieve for your patients.
Sure. Yes, so as I'm scaling back on my gastroenterology practice, I realized that really my passion lies in the metabolic disorders, of which fatty liver is one, steatotic liver disease is one. And so I really wanted to devote more time to that. And everything is really pointing toward a team approach to treating these types of patients. And we know that anyone with metabolic syndrome, steatotic fatty liver disease, insulin resistance really requires a change in nutrition, a change in physical activity, and change in multiple behaviors. And so we brought together a team, myself and a nurse practitioner, a fitness expert, and a certified health coach, where we are all working together to surround the patient to really get them moving in the right direction and keep them motivated to continue to make those changes.
Does an individual know that they have these type of problems? Just on a regular basis, whether whatever it is they're eating or they're not exercising?
No, I mean that most of them sort of know, but they really don't
gotta
know.
get out there, right?
They know that they need to be doing something, but they don't quite know what to do.
Okay.
And unfortunately, a lot of the generic nutrition advice that you're going to get online is really sort of geared toward the healthy person. You know, the dietary guidelines are really meant to be guidelines for healthy people. These people have metabolic syndrome that we're seeing. Anyone with metabolic syndrome, we teach them that is a carbohydrate intolerant state. You have high insulin. So it doesn't make sense to give someone in this state whole grains and things like that are going to raise their insulin even higher. We want them to be what we call therapeutic carbohydrate reduction, where we're lowering the carbohydrates to allow insulin levels to come down.
Yeah. Just like Bruce Springsteen sang, Mama always told me not to look in the sun, but Mama, that's where the fun is. And you're talking about carbohydrates, and
that's where the fun
good
is.
Stuff, man. You're talking about soft drinks, right?
Yes.
And you're talking about, and I mentioned this off the air to you, I used to keep Little Debbie in business. And,
Absolutely.
But those are, and I'm a type 2 diabetic. Okay. And so those are all things that will only contribute to that in the long run.
Absolutely.
Why do they make the stuff that's so good that we can't have?
Because they want you to eat it. And everyone struggles with that.
Yeah.
I've struggled with it. I mean, I shared with you, I had signs of insulin resistance. And this gets to another point that we try to make, is that it is not about the obesity. Yes, obesity is an issue, absolutely. But one of the latest studies looking at components of insulin resistance and metabolic syndrome found that nearly 90% of the public had some element of metabolic dysfunction. It didn't matter whether you were obese or thin. I have been thin my entire life, and I still got insulin resistance. 2/3 of the people in this study that were thin had a component of insulin resistance. And so when we put the focus only on obesity as a disease, we do a huge disservice to the millions of thin people out there that have true metabolic dysfunction. And everyone's looking at them and saying, oh, you're great, you look great. Yeah. But they're not great.
Well, if the audience could look at this and see it, the insulin resistance portion of it, that it goes to the pancreas, right? And the pancreas it affects the liver. So all these internal organs work together.
Yes. Yes.
And eventually they're working to destroy the liver?
Well, as the first thing that happens is the liver starts to begin to get fat in it from a variety of different reasons. And as that fat can continue to accumulate for whatever reason in that individual patient, they may go on to get inflammation in that fat as well. And once the liver becomes inflamed, those are the people that begin to have the higher risk of going on to develop advanced scarring, cirrhosis of the liver, cancer of the liver.
But there's good news about this. If it's detected, if you diagnose it, that it can be turned around.
Absolutely.
You have studies that prove that this stuff, you can have scarring in your liver, you can do this and have, what do you call it, NASH or something like that?
Well, it's now called MASH.
MASH.
Yes.
Okay.
And metabolic instead of non-alcoholic.
Okay. And that can all be turned around.
And that can be turned around. We have, there's so much hope in the field right now. I mean, for patients that just have steatotic liver disease without any advanced fibrosis, we know that lifestyle changes can reverse this completely. We were talking before air that we have dozens of patients at our office now on liver scan who have reversed their fatty liver completely. But even now for patients that do have advanced fibrosis, there is a drug that's been conditionally approved in 2024 for fatty liver, steatotic liver disease with fibrosis, and this drug is improving fibrosis.
Okay. We're going to talk about that and more coming up. So there is hope and there is help. You just got to follow the doctor's orders. Dr. JEROME-ZAPADKA, Dr. Karen JEROME-ZAPADKA is our guest. We'll talk more about Trajectory Health Partners and how you can get involved next on the Best of Beaver County.
I'm Patty.
And I'm Bob. We're retired and we live at
is our guest. She's a gastroenterologist, and now she's, over the years, I shouldn't say now because you've been working on this with the Metabolic Task Force and the Liver Education Advocates. You're involved in all these different organizations, and you're bringing it to folks not only in Beaver County, but you opened this Trajectory Health Partners, and it's located in Cranberry Township, but you're attracting a lot of different people and patients to this because you're waking us all up to what's going on internally and how we can live better lives. And at my age, at our age, that you can live longer. You can help yourself live longer.
Longer and better.
And better, okay. And what's the sense of you living longer if you're not living better?
Absolutely.
Right? Because you can live till you're 85, but you're in a home and, hooked up to tubes and all kind of other things. So that's not helping you.
Absolutely. Okay. Longer and better.
When we went to the break, you talked about there's medication out there and everybody likes that. I can lose weight. Give me a pill to lose weight. Nobody wants to do the work. But now with this liver talk and MASH, there is a prescription out there that is available to people.
Yes, there is a drug. It's called Rezdiffra. It works in the liver at a thyroid receptor in the liver. And the studies do show that it improves liver fat and liver fibrosis. So it is actually the first drug that has been conditionally approved to treat steatotic fatty liver disease with fibrosis. So this has been a really exciting development over the past year. There are other drugs in the works that are exciting as well. The GLP-1 agonists, Ozempic, semaglutide, will be a drug that we will be using, and I have used in certain cases for this as well.
I'm in over my head. You keep mentioning things that I'm thinking, okay, now what's that mean? And because you just threw thyroid in there with pancreas and liver and all these other things.
Yes, well, it's not actually the thyroid gland. It's actually the thyroid receptor in the liver. The liver has thyroid receptors, and that is where Rezdiffra works.
The only time that most of us, and I don't mind saying this, the only time that most of us have ever heard or talked about liver is, I know when I was younger, every once in a while we'd have liver and onions, and you'd see the liver there, and you fry it up in a pan. Nobody knew that much about it. But we can do damage to it, or if your liver is healthy, that changes your entire system.
Yes, I think that is one of the most important things we try to teach patients is that if you have steatotic fatty liver disease, it is a systemic disease. It is not just confined to your liver. In fact, the talk that I gave this past Saturday at the health event was alongside Dr. Chris Morgan, one of the cardiologists, because we understand that cardiovascular health and liver health are intricately involved with each other because of these metabolic issues. And so once you do have steatotic fatty liver disease, you are at risk for a whole host of other issues: chronic kidney disease, cardiovascular disease, multiple cancers. In fact, the two biggest causes of mortality in people with fatty liver are heart attacks, in the layman's term, and cancers. And liver cancer is one of the fastest growing cancers that we have now because of this epidemic.
And people say, well, you know what, I have more years behind me than I have in front of me. What can you do about it now? What can I do to change it?
Yeah, I used to think that way too. One of my most inspiring patients was a woman that was 75 who came to my center and knew she had fatty liver and wanted to improve it. And I'm thinking, oh my gosh, she's 75. Do we even want to get into this at this point? But she really taught me a lesson. She threw herself into it with the right nutrition, with the physical activity, did our resistance band workshop. And at 75, she went from someone who basically sat around most of the day to, the last time I saw her, she had laid 50 bags of mulch in one afternoon in her yard herself, and could not believe.
You think she'll come to my house?
And that really taught me a lesson that it doesn't matter the age. If you can gain back health and energy, no matter what age you are, why would you not want to do that?
Right, exactly.
And every patient that improves their insulin resistance improves their energy level. And that's one of the first things every patient says when they come back. I cannot believe how much more energy I have.
Okay. Let's talk about Trajectory Health Partners. How do people watching this, listening to this, do they have to be referred to you? Or?
No, well, you can be referred, absolutely, but trajectoryhp.com, that's our website, and on the website is a portal where you can enter your information if you'd like to be called about more information or call to make an appointment. Patients can make appointments on their own.
Okay. And then you go through a wide range of tests on the individual to see, or have they already been diagnosed with fatty liver?
It's variable. A lot of them have already been diagnosed with fatty liver, or in some of them we've made the diagnosis of fatty liver. We get a number of blood tests. We're doing this scan now, the Velliker scan, that looks at how much fat is in the liver and stages it as far as is there any scarring in the liver. And then we decide what other blood work they need, and then we develop a plan that we help to implement with our health coach.
So this, you don't have to have a liver biopsy?
No,
it's something that can be found in the blood?
Oh, yes. Yeah. In fact, that's the big push now. They call them non-invasive tests or non-invasive liver disease assessment. Those are the new terms now that are really looking at how can we assess the stage of the liver with imaging and blood work that can give us a good clue about whether they have advanced fibrosis or not. That's what we really want to know when we see a fatty liver patient. Do you have advanced fibrosis or not? And oftentimes we can gather all that information and make a very good determination without a liver biopsy.
Do you think that the medical community has been aggressive enough in fighting this or trying to work with people? Because you go to your regular doctor, your primary physician, and they say, yeah, you got this, just walk a little bit and you'll be okay. So, but should we be more aggressive towards it?
Oh, absolutely. I think on two fronts. I think on the first front, we need to be more aggressive about screening people for early insulin resistance. At this point in time, the vast majority of medical physicians are not measuring an insulin level. And so I think one of the most wonderful tests is to measure a fasting insulin and a fasting glucose. And then on that, you can calculate out a score called a HOMA-IR score. And that will give you a very good clue about whether you're insulin resistant or not. The problem is if you wait until someone becomes pre-diabetic where you really know they're insulin resistant, you've been insulin resistant for at least 10 to 15 years. You've had high insulin levels. That high insulin itself has its own detrimental effects all throughout the body, and no one's measuring for it and no one's talking about it. But that is the other side of the coin of insulin resistance. If you have insulin resistance, you're going to have a high insulin level, and that high insulin level is very detrimental to your body.
I think a lot of people have a tendency to just be lazy about it and say, just give me a shot. Can I get a shot? Can't you give me a shot of insulin or something and it'll be okay and I can eat whatever I want?
You can eat whatever you want. That's I think is what everyone wants. We want that a way that we don't have to do too much. And the problem is the drugs will all help some, but unless we change the core nutrition, the driving factors of that insulin level, starches, sugars, the metabolic effects of fructose that have nothing to do with calories, but what it does to the liver intrinsically, unless we remove those foods or lower them to an amount that we can tolerate physiologically, all the drugs in the world are not going to completely get this turned around.
So what are we eating? What do we drink? We talked about pop or soda, and whether it's diet or regular, it's still carbohydrate, and it's still bad for you.
Yes, so I think with regular pop, I think it's twofold. It has sugar in it, but sugar we have to look at is both the glucose component of sugar and the fructose component of sugar. So the glucose will raise the insulin, again, promoting high insulin levels and insulin resistance, making it harder to reverse that. But the fructose is the other component of sugar. And this is, again, what we try to teach our patients. Fructose has a very unique metabolism in the liver. It's very similar to alcohol. It's not related to its calories. It's related to what it does to the liver cell. And it is a toxin to the mitochondria of the liver, the little powerhouses of the cell, what we used to think of as the powerhouses of the cell. Fructose is a toxin to the mitochondria, a chronic mitochondrial toxin that makes the liver worse at burning fat, it makes the liver burn fat, and it shuts down energy production in the mitochondria. So it makes fat and it makes fatigue. And that is very unique to fructose. And fructose's other actions all throughout the liver basically culminate in all the features of metabolic syndrome.
Okay. And so eating, it's getting close to lunchtime here, and people will go out and they'll have a hoagie, they'll have a sandwich. We grew up on, cold cuts and all those other things, whether it's meat and potatoes. We all used to pride ourselves in, well, we grew up on meat and potatoes, but a Mediterranean diet is more helpful to a person's system.
I think a Mediterranean diet, and there are lots of definitions of a Mediterranean diet, so I'll put that out there. I think the concepts of eating lower in like extra virgin olive oil, non-starchy vegetables, I think those nuts could all be part of a good diet. But I think in someone who has metabolic syndrome, if I talk to them about a Mediterranean style of eating, it is definitely a low carb Mediterranean style of eating. And mostly we just talk to them about what do you really need in a diet. You need amino acids from protein. You need fatty acids from fats. There is no essential carbohydrate. Our body, if we need carbohydrate, makes it ourselves. So eating-wise, we don't have to eat any carbohydrates at all. Though I'm not saying everyone should be off of carbohydrates completely, not at all. But I'm saying they're not essential like proteins and fats are. And so we try to build a nutrition plan that's based upon prioritizing their protein, the correct types and amounts of fats, and then getting their carbohydrates in the form of non-starchy vegetables.
Yeah, and you can learn all this by coming to Trajectory Health
Absolutely.
Partners. Fruits and vegetables. Fruits are high in fructose, are they not?
Fruits are definitely have fructose. Some fruits are much higher in sugars than others, and so I think again it's working with the patient and trying to get them onto the lower sugar fruits like berries, which were good.
All right. Once again, Trajectory Health Partners. Dr. Karen JEROME-ZAPADKA is our guest. She's the founder and the medical director. How can people get in touch with you? You mentioned your website a little earlier. How do people listening to this program say, you know what, we should look into that. We can live healthier and we can live longer.
Yes, absolutely. So I think we're really gearing up to see people with true metabolic dysfunction. So anyone out there that has elevated triglycerides, low HDL, the central obesity that we talked about, diabetes,
that's belly fat. I found that out. She said central. What was it?
Central obesity.
Yeah, and I said, is that belly fat? She said, yeah, that's belly
that's
fat.
belly fat. Yeah. So any of those markers, absolutely, they would qualify as someone that has some metabolic dysfunction, and we would love to see them.
And insurance, because a lot of people say, will my insurance be covered?
So my nurse practitioner and I, we are credentialed with all of the insurances around here. So our visits are billed under insurance. The Veliker liver scan is paid for by most, but not all insurances. And then we're a hybrid, so we charge cash fee for the health coaching, and if they decide to do any of the exercise, the fitness instruction, those are cash fees.
Trajectory Health Partners is the name of the organization. The new office located in Cranberry. You can Google that and get in touch and be on the way to healthy living. Thank you so much.
Oh, thank you for having me. Likewise.
Dr. Karen JEROME-ZAPADKA on The Best of Beaver County.
Thank you for listening to The Best of